Okay, for our next talk, we have Dr. Kenneth Bandito again, from Chicago Anesthesia Pain Specialist, board certified in anesthesia and pain management, recipient of the Board RACS Award from ACIP in 2021 for excellence, and he's served as department chair of anesthesiology at Advocate Illinois Masonic Medical Center in Chicago from 2007 to 2021.
So a show of hands, how many people have never had a complication with their interventional pain management procedures? Liars. So we'll talk a little bit about complications today. Obviously it's a hot topic, it deserves a lot of attention. And it's a topic near and dear to my heart because I probably had almost everything that we can ever see with interventional pain. I think if you do enough procedures, that's bound to happen. I have no disclosures, at least as relates to this educational activity. So I have three famous sayings that I like to always remind my fellows of. Those who forget the past are condemned to repeat it or relive it. That's from the great George Santayana. And my mentor, Alan Winnie, was very popularized that saying. Of course, some would attribute it to Confucius many centuries before Santayana, but it's true. If you don't learn from the past, you're going to make the same mistakes as others. There's no reason to do that. It's better to be lucky than good, that's true. And good judgment comes from experience. Unfortunately, experience comes from bad judgment. So hopefully we don't have to make the mistakes of other people. Here's a nice paper from Jim Rathmell, which was recently published in Anesthesia and Analgesia. And I found it phenomenal. It's a 7-year review of malpractice claims in the United States from about 400 teaching and community hospitals. There were 400,000 medical malpractice claims. And what Rathmell and his associates did was they just used keywords related to regional anesthesia and interventional pain. And they found 126 closed claims. Now, that doesn't mean that there were 126 adverse outcomes. That means that someone elected to either have a jury trial, which was found either in favor of the plaintiff or the defendant, that's us, or there was a settlement made. So there were 126 claims that were already closed. The median payment was $175,000 with a maximum of about $3 million. Lumbar, interlaminar, epidural steroid injections were the most common reasons for these claims. That doesn't mean they're the most common reasons for errors, they're the most common reasons for claims. Improper performance of the procedure and alleged non-sterile technique were the most common complaints. And perceived deficits in technical skill were found 83% of the time when there was a judgment made against the practitioner. 83% of the time, we were determined not to have the appropriate technical skills. So lumbar epidural steroid injections, interlaminar, cervical epidural steroid injections, interlaminar, and then down here, transferable injections were less likely to lead to a closed claim. Again, we're not attributing a numerator or a denominator here at all. We're not talking about the total number of cases which were done or the total number of complications. But improper performance of the procedure was found about 83% of the time. At least that's what our juries of our peers determined. And other things like spinal cord needle trauma were found with a high percentage. Interestingly, and I think it's important right now, if those of you who do interventional pain procedures, when you get a consent form on your patient, all my consent forms tell patients that their pain could be worse than it is upon arrival to my practice or before the performance of the procedure. You better put that in your consent form, because the number one claim against us is that my pain was worse. I never knew my pain could be worse. You have to tell your patients that pain can be worse after a procedure. How about technical skill? 83% of the time, we were judged not to have the appropriate skill or have poor clinical judgment. Alan Kay and Associates, you all know Alan, editor-in-chief of the journal Pain Physician, big name in ACIP, looked at 30 years worth of data, 30 years worth of malpractice data. And they found the good news is that in the majority of cases, 57.3% of the time, the judgment was found in favor of the proceduralist or interventionalist. So that's good news. The bad news was, unlike what Rathmell found, where the median payment was $175,000, Alan Kay's group found it was almost double that. And they found that there was an award for $36 million against a practitioner for sensory nerve injury following an axial procedure. Those procedures that were performed in the operating room tend to result in an adverse outcome to the practitioner more commonly, more than 83% of the time, compared to when they were done in the office. And procedural error was, again, the number one reason why people were sued. The great state of California, where we're now sitting, was overwhelmingly the number one state where these types of lawsuits occurred. So those of you who practice here, take solace in the fact that you're in the state with the highest rating for malpractice claims. Out of 50 or 28% of all cases happening here in California, followed by Florida. Age of claimants or plaintiffs is in the mid-40s. Females and males are about equally distributed. And you can see that the people voted in favor of the proceduralist more commonly than the patient. Sensory nerve injury, motor nerve injury were about equally representative. But again, one payment was made for $36 million. Procedural error, lack of consent, lack of judgment. These are the recurring themes. Don't forget in your consent form, tell your patients that pain can be worse now than it was prior to their procedure. Sensory and motor injury, equally distributed. Mixed injury compared to isolated sensory, whether it's a neuraxial procedure or a peripheral procedure, equally represented. For those cases that led to an award or judgment, about 2/3 of the time, actually, the defendant, that's us in this room, we were exonerated 2 out of 3 times. For facet joint injections, where there was money at stake, it was 50-50. With intrathecal pumps, and 100% of the cases were limited, there were only 7 awards noted. It was always in favor of the patient or the plaintiff. So epidurals, we do pretty good. Facet joints, it's a mix, 50-50, whether we pay or whether we get off scot-free. And with intrathecal pumps, the patient always seems to get an award. So let's talk about these worst-case scenarios. I want to mention 3 scenarios: paralysis, infection, and death. I think we'd all agree in this room that those are complications, right? You paralyze somebody who walked into your office, that's a bad thing. You cause an infection in somebody who didn't have an infection coming into your office, that's a bad thing. And of course, if you kill somebody who comes into your practice, that's horrible. Let's talk about transformational versus intralaminar epidural injections. How many people in this room do exclusively transformational injections for lumbar radicular pain? Exclusively. How many do interlaminar injections exclusively for radicular pain? How many people do both, transforaminals and interlaminars? Okay. So, interestingly, here's a recent paper from Chang and Eng, which was published last year. Complications with lumbar transforaminal epidural steroid injections. Minor complications occur in about up to 9.5% of patients. Manchakanti's paper showed that we have things like intravascular penetration, return of blood, and profuse bleeding, which is very, very rare. But this article also outlined the case reports of serious consequences from transforaminal injections. Paraplegia, epidural abscess, paraplegia, epidural hematoma, dural puncture. And so these are the case reports with transforaminal injections. So why do we do transforaminal injections? Well, because we know that the intervertebral disc has 7 chemicals of inflammation. Those include histamine, lactate, bradykinin, substance P, calcitonin G-related peptide, vasoactive intestinal peptide, and phospholipase A2. 7 chemicals that can be liberated at the time the disc degenerates or there's an annular tear or rip. And many people have hypothesized that the interface between the disc here and the dorsal root ganglion, which is the nociceptive site where many of these signals emanate, the best way to get at it is to do a transfemoral injection, right? Any disagreement there? None whatsoever, right? You go right at the target, you put your medication down at the interface here. An epidural injection may be a little bit far removed from that site. At least that's the theoretical hypothesis. In fact, Jim Rathmel and Steve Cohen wrote this paper in Regional Anesthesia several years ago with 317 references, and they said, well, sure, transfemoral injections are superior to interlaminar injections, but this was not based on a meta-analysis of the data. It was not based on a systematic review of the data. This was a purely opinion piece by Rathmel and by Cohen. In fact, there was bias here. Why was there bias? Because they presume that a transforaminal injection puts the medicine directly over the dorsal root ganglion, whereas your epidural injection is far removed here from the site of nociception. And so this is what they stated. All epidural injections are midline. Well, they're not. If you move the needle off the side in a parasagittal fashion, you actually can put the medication directly in the same location that is covered by a transforaminal injection. So on April 23rd of 2014, the United States Food and Drug Administration issued this black box warning. And they said that all interventional pain physicians should tell all their patients that epidural steroid injections can cause blindness, paralysis, stroke, or death. And I found this interesting. There were 17 references to this announcement. 14 of the 17 references were about transfemoral injections only. The other 3 included things like trigger point injections and facet injections. So I marched down to Silver Spring, Maryland to confront the FDA along with Dr. Manchiconti and others. We said, wait a minute, this is wrong. Not all epidural injections cause blindness, paralysis, stroke, and death. And we wrote a paper about it, myself and Tim Deere and some other folks. We said, you got the message wrong, folks. Because, yeah, you had the message right that injections can cause blindness, stroke, paralysis, and death, but it's not interlaminar injections that do this, it's transfemoral injections. And we recommended that the FDA change the language, which in fact they did, to reduce the fact that clinicians had to go across the country and tell all their patients that their epidural injections could cause blindness, stroke, paralysis, and death. In point of fact, they do not, but transfemoral injections can do that. And so myself and Manchiconti and others, Benjamin, Garibo, Josh Hirsch, stated that the multidisciplinary workshop group, which had made suggestions, had made gross errors in trying to equate a transfemoral injection to an interlaminar injection. And so if you think about it, you can do an interlaminar injection off the midline and get exactly the same success as a transfemoral injection from the side, but avoid the radiculomedullary artery. So here's the radiculomedullary artery, and you see it's directly in continuity with the exiting spinal nerve root. So why are transfemoral injections done? Well, some people like them. I'm going to talk about that in just a moment. But there's always this lurking possibility of directly contacting and injecting into the radiculomedullary artery. And if you put a particulate or an insoluble steroid in there, like methylprednisolone or triamcinolone, it can cause infarction of not just the nerve root, but also of the spine. And so some individuals, like James Rathmell, hypothesized that if we use digital subtraction angiography, we could avoid that risk. We could avoid the risk of intravascular injection. How many folks use DSA as a part of their routine practice? Interesting. And so about 10 years or 8 years or so ago, I was working in Chicago, and my resident at the time, George Chang Chen, said to me, wow, I was at the Rehab Institute. At one of the major medical centers in Chicago, they paralyzed a patient with an L5-S1 transfemoral injection. And they used a test dose of local anesthetic, and they used extension tubing, and they used digital subtraction angiography. I said, wait a minute. Some folks are saying DSA avoids the possibility of paralysis. And so here's the actual images. The patient gave us permission to publish the results of his case. And so you see the needle coming in over here, you see the cine angiography. Remember, DSA exposes your patient to 10 to 15 times the X-ray radiation that a normal fluoroscopy image does. And not only does it expose your patient, could you imagine if you're doing 20 or 30 or 50 procedures a day in your practice, and you multiply that exposure 10 to 15 times, each case times the 50 cases you're doing. Your patient may not be at risk, but you and your X-ray tech and your nurses and your medical students are at an inordinate risk for developing lymphoma or some other catastrophic event. Anyway, patient comes in, they have the transfemoral L5-S1, excruciating pain in the chest, goes for an immediate MRI, there's an infarction of the spinal cord from T7 all the way down, permanently paralyzed for the remainder of his life. Now, how did that happen? It was an L5-S1 transfemoral injection when DSA was used. Well, they injected either into the artery of Depolation or a radiculomedullary artery, which was large and which was in continuity with the artery of Adamkiewicz, which is supposed to end at L1. Well, guess what? There are case reports of the artery of Adamkiewicz going all the way down to L5-S1. We don't really know. Here's another major medical institution in Chicago where a transfemoral injection at L4, L5 caused permanent paralysis, and the defendant anesthesiologist settled the case for $2.3 million with DSA being used. DSA is not infallible. Here's another case that happened walking distance from my home at a place called Hinsdale Hospital, beautiful little community hospital, by an ACIP member, somebody who's very good at describing the catastrophes with transfemoral injections. $6 million for permanent paralysis. Now, think about this though. Why did they do a transfemoral injection here at T12L1? They did it for compression fracture pain. How many people in the audience use transfemoral steroid injections for pain from a vertebral compression fracture? And so obviously this is arguably poor judgment, poor technique, and a catastrophic outcome. So DSA does not really protect you, ladies and gentlemen. I'm sorry if you went out and spent $40,000 to add this to your fluoroscopy equipment, or you went out and bought some special unit to expose you and your patients and your x-ray test to 10 to 15 times the amount of radiation that they otherwise would be. And we showed this unequivocally. We did a meta-analysis and systematic review of all the studies ever published on DSA. And George Cheng Chen was up here in Los Angeles, who was a great, great resident of mine, did his pain fellowship at the Cleveland Clinic. We looked at the studies and we said, routine use of DSA is not warranted. In fact, we went back and Meet Nagpal and George and I, and Monak Rana and Max Ekman and others. We looked at the 383 articles where DSA had been referenced and found that you could not make a definitive conclusion that DSA identifies vein versus artery. And that's really where the rubber meets the road. If you can't delineate what is a vein versus what is an artery, then you can't protect your patients. So why do we do transfemoral injections? I mean, I just showed you that they can lead to catastrophic outcomes. I just showed you that the FDA got the message wrong because 14 of their 17 references that talk about blindness, paralysis, stroke, and death are only about transfemoral injections. So obviously we do it because transfemorals are more efficacious than interlaminar, right? Raise your hands if you believe your transfemoral injection has greater efficacy than interlaminar. Okay? So what does the data show? Well, we did a meta-analysis and systematic review of all the studies that ever looked at a head-to-head comparison of transfemorals versus interlaminar. We published this in Pain Physician a couple years ago. Andrea Trescott was on the paper, Zach McCormick, myself, and others. And we found 5 good papers, 506 total patients, patients with unilateral radicular pain, no prior surgery, et cetera, et cetera. And these are the studies here. You can look it up if you have an interest in it. And at 2 weeks, the evidence favored a transfemoral injection over interlaminar. That's good, right? For those of you who favor transfemoral injections. At 1 month, there was no difference. At 6 months, there was no difference for your patients whether they had an interlaminar injection or a transfemoral injection in terms of pain reduction or functionality. And this study has been replicated by Babita Ghai in India and other people who've looked at more studies now as they've accrued comparing interlaminar versus transfemoral injection. So there's no clinically significant differences in efficacy for pain relief or functional improvement whether you do a transfemoral injection or interlaminar injection. So why do we do transfemoral injections? Who's going to tell me what the real reason is we do transfemoral injections in this room? Who's going to be bold and tell me the truth? Money. We do it for money. Money, money, money. And so this phenomenon of paralysis occurs everywhere. It occurs on the left, it occurs on the right. And we've hypothesized it's due to the injection of insoluble steroids, methylprednisolone and triamcinolone, into a radiculomedullary artery, although that really hasn't been proven unequivocally. I give credit to Rick, and these studies go back 20 years. Here's Tom Errico, a surgeon at New York Hospital, who actually studied this phenomenon, published it, Mark Huntoon and others, many, many case reports, but really a lot of credit goes to Rick Tizo. Rick Tizo is a practicing anesthesiology pain physician in New Jersey. And in 2003, Rick Tizo was doing a cervical transfemoral injection on a patient and paralyzed that patient for life. The patient became quadriplegic. But rather than run and hide, Rick said, this is unbelievable. How did I paralyze this poor guy? And so he went back and he looked at the particulate size using scanning electron microscopy and found out what percentage of methylprednisolone, triamcinolone, beta-methasone, and dexamethasone had particles greater than 100 microns, because we know that the artery size is greater than 50 microns, metarterioles are 20 to 50, etc. And he said, if I paralyze this patient, I must have embolized this steroid. And so methylprednisolone was found to have the greatest percentage of particles. Here it is MPA, here's triamcinolone, here's beta-methasone, here's dex. And he said, well, maybe we should not be using methylprednisolone or triamcinolone for transfemorals. So studies have been done that look at, for example, using dex. And guess what? The people who get dex have to have more injections. It doesn't last as long. And the surgery rates are much higher with dexamethasone. I don't have time to go into that, trust me. Also, there's the phenomenon of intra-distal injection. We published a paper on this a few years ago. Myself, Jeff Katz at Northwestern. We found that the incidence of intradistal injection with transfemorals is about 10 times higher 0.2% versus 0.02% versus interlaminar injections. So we get down to the rubber meets the road. Why do people do transfemoral injections? Be honest, we do it for money. It's true. And so we know that as Medicare data, interlaminar injections versus transfemoral, we see that lumbar transfemoral have skyrocketed in the last 10 years. Nick Nesovich and I published a paper in the journal Anesthesiology saying, do we have an alternative to transfemoral injections that's just as good? And the answer is yes. We got the parasagittal interlaminar injection. And why are people doing it? I'm sorry for why this came out, not the way I published it, but we do it for money. We do it because the reimbursement for transfemoral injections is 150% higher than for interlaminar injections. So let's be honest. If you're doing 10 injections in your office and you can make $100 per injection with interlaminars, that's $1,000. If you make $150 per injection with transfemoral, you walk away at the end of the day with $1,500. It's easy for people to fall into the trap of saying, well, I got car payments, mortgage payments, ex-wife is bugging me, kids about to go to school, I got to do the transfemoral injection. But don't try to rationalize it by fraudulently saying that the efficacy is higher. It's not. Or that the outcomes are superior with transfemoral. They're not. Or that the risk-benefit ratio favors transfemoral. It does not. We do it for one reason. The reason is economics. And so Nick and I published the data. Here's CMS Medicare spending. Transfemoral exponentially higher than interlaminars, except for cervical, where people are not doing nearly as many cervical injections as they were historically. So there's no medical or scientific basis for choosing a transfemoral injection. I'm not critical if you do it. I do them occasionally. DSA use doesn't help you. If you choose to use dexamethasone, you're going to be sending more patients to surgery, doing more injections. And let's move on to infection. So according to the CDC, there's 3 types of infection: superficial infection, deep incisional or organ or space. Gratefully, most of the things that we see in interventional pain are superficial incisional infections. And we see that about 3.5% of the time we do our stims and our pumps. That's still a level of infection which is much higher than it ought to be. Deep incisional is where there's pus or abscesses in the fascial and muscle layers. Here's a superficial site infection. How many have seen this with their pumps or their stims? You see this occasionally, right? Pretty easy to treat. Deep surgical site infection, this is very rare, but does occur sometimes with our implantables. And of course, epidural abscess, you see the abscess right here, or osteomyelitis, those are the endpoints of very serious deep infections. So who's at risk for getting an infection? Well, obviously, if there's endogenous contamination, we don't do this. We're not doing a lot of bowel procedures as interventional pain physicians. If there's exogenous contamination, which means prolonged operations. And so if you get an infection, you may not know this, but your hospital infection committee is probably looking at your surgical operating times, because they know what the national averages are for placing a spinal cord stimulator or an intrathecal drug delivery system. And if you're at the 75th percentile, meaning slower than 75% of your peers, you could be you can be exposed for that happening. How about things that diminish the efficacy of the general immune response? A lot of our patients get steroids, for example, and we do place foreign bodies in our patients. So the National Nosocomial Infection Surveillance System actually produces a list of 8 factors which are associated with a higher than normal incidence of infection, and that includes patients that we operate on who have an ASA pre-op classification of 3 or greater than 3. And many of our elderly patients, of course, are ASA 3s or 4s. We don't do a lot of procedures that are contaminated or dirty, and here's where you have to take serious consideration. And I train residents and fellows, and in my first 12 years of practice at my current job, we had no fellows, and pretty much we had 0 infections, even superficial infections. Once we started training fellows at our operating time, we're about at the 75th percentile, because obviously there's a learning curve. We had a couple of infections. Each year we had fellows that we never had before. So it's a real phenomenon. So these are the 8 things which are associated with a higher than normal incidence of infection: advanced age, ASA classification greater than 3, malnutrition, low serum albumin, radiotherapy, chronic steroid use. And then these 2. Now this was a national survey where they said obesity and cigarette smoking was associated with a higher than normal risk of infection. Obesity and cigarette smoking. And so we thought about this, and we went back and we actually studied this in a prospective way. And we had 70 patients that we studied for permanent implantation. And lo and behold, first thing we wanted to look at was whether efficacy was somewhat influenced by patients who were obese, including body mass indices up to 40, or whether smoking influenced the efficacy of our procedures. And it did not. all our patients did pretty much across the board well, whether they were smokers or whether they were obese or not. And then we wanted to study whether obesity not only affected the efficacy, but also led to increased risk of complications like infections or lead migration, and it did not. So in Chicago, we were able to prove definitively with these 70 cases or so on a prospective basis that obesity by itself is not a risk factor for infection. What about smoking? Once again, smoking was not an independent risk factor for infection. What smoking did cause was an increase in lead migration, leading to an increase in the need for revision. So smoking, I guess because these guys or ladies are coughing more, they may be moving more, who knows what, or going out and doing more things, who knows what, but there was more lead migration leading to revision in smokers, but they did not have a higher incidence of infection. So why is infection important? Because it increases the costs. Patients are more likely to be admitted. They're more likely to die, twice as likely to die with an infection than without. And of course, the rates have not fallen. We have not done a good job of minimizing the 3.4 to 4.5% incidence of infections with our implantables. Tim Deere and others, Nagy McHale, Dave Provenzano, looked at this. And we tried to find steps which a commonality in who had lower infections amongst implanters. The number one thing that leads to lower infections are experience and education. So the more you do, the less likely you are to have an infection in their practice. Nationally, we see the infection rate for joint replacement is about 2%. And so all of our societies are aiming at reducing implantable infection rates down to 2%. Presently, they're at 3.4 to 5%, however. 3.4 to 4.6% of our implanted devices continue to get infected. The process study from Medtronic, where they looked at the use of neuromodulation versus conventional medical management, there was an 8% infection rate in that trial, which was published several years ago. Best case scenario, antibiotic use, major surgery, sometimes loss of system, and of course, increased medical costs. Nagy McHale at the Cleveland Clinic studied this as well at over 700 patients who had implantable spinal cord stimulators and found a 4.5% incidence of infection with implantable devices. Interestingly, I found the data very interesting. They were twice as likely to have infections in patients who had STIMs for failed back surgery syndrome than for CRPS. They were twice as likely to have infection in patients who had neuropathy, STIMs placed for neuropathy, than for CRPS. I know Dr. Helm's going to give us a great talk on CRPS in just a few moments, but it appears from McHale's data that there are certain surgical indications for neuromodulation that lead to a higher than expected infection rate. This was a nice paper by Jan Rudiger and Associates that they suggested the infection rate may be as high as 13%, although in their own unique study they found the infection rate was only 4.5%. Mitch Engel showed that the higher the NNIS, the infection survey risk was, the more likely people were to have infections. So I'll go through a couple of scenarios now about infections, prevention of surgical site infections. This comes from Tim Deere and David Provenzano. Use weight-based antibiotics. I hope when you're administering your pre-procedure antibiotics for your patient, you're calculating it based on their body mass index and their weight. Make sure you use clippers to remove hair immediately prior to the procedure. Don't have them shaved the night before. Don't have somebody come in at the bedside and do this 24 hours before. And appropriate agent selection for antisepsis. So how often are we doing the right thing? Effective or electric hair clipping when necessary, 76% of the time. Screening patients for MRSA, we're doing that about 80% of the time. Appropriate antibiotic selection, pretty high actually. Weight-based antibiotic dosing, we're only at 50%. Skin prep using chlorhexidine and alcohol, that's really a CDC 1B recommendation. Meaning you ought to be using chlorhexidine and alcohol. How many people use betadine to prep their patients back before a stimulator or a pump? Well, you ought to be switching to chlorhexidine and alcohol based on the Center for Disease Control, and I'll show you that in just a minute. Betadine is not considered to be an appropriate agent or the most effective agent in that regard. Wound irrigation happens about 2/3 of cases. So here it is, CDC 1B recommendation. This was published more than 10 years ago in the New England Journal of Medicine. If you missed it, you ought to be using chlorhexidine and alcohol because the risk of infection is about half when betadine is used. So this is going to be something, if you get an infection in your case and you have an expert witness testifying against you, and they looked at your skin prep as betadine, not chlorhexidine alcohol, you could potentially be liable for the outcome for that patient. You ought to be using chlorhexidine alcohol in all your preparations for all your permanent implanted devices and for your trials. You ought to be using a weight-based dosing for your antibiotics as well. Bio-occlusive dressings, we do that pretty much. Wound surveillance, we don't do enough of that. post-operative antibiotics. How many people give antibiotics after your implant has been placed? And the vast majority of us do some of that as well. So this was a nice international survey to understand infection control practices by Dave Provenzano, Tim Deere, and others. And they found most of the respondents were Americans. Many of them, however, more than half only did less than 20 implants per year. However, the good news was that the vast majority had less than 90 minutes surgical time. How many people have more than 90 minutes to put in a stimulator or pump? On average, no, exactly right. And so what did they find in this survey? That 3% of individuals were not using antibiotics. That's really unacceptable. Most people were giving antibiotics between 1 and 60 minutes prior to skin incision. That's good. That's the way it ought to be. How about skin depolation, taking the hair off the body? About 75% use clippers immediately before. That is the appropriate choice to remove hair before your procedure. What to use to clean the skin? Only about 1/4 of clinicians who responded to this survey were using chlorhexidine alcohol. Remember, that's a CDC 1B recommendation. You ought to be using chlorhexidine and alcohol, not betadine for your patients. How long do we use antibiotics during the trial? 70% used during the duration of the trial, but 10% didn't even use them for 24 hours. I used antibiotics throughout the entire duration of the trial. How about after a perm stim? Again, the vast largest respondents used antibiotics after their perm for up to 4 to 7 days. I used them for up to 10 days. Golden rules, and then I'm going to try to finish up because I'm kind of eating into Dr. Helm's time, and I apologize. If you have a patient who presents for an infection, always assess the patient, look at the patient, examine the patient, look for things like an elevated white count, sed rate, and C-reactive protein, in addition to all the usual signs of infection. And these are 3 of my own cases. Infection or no infection. This is a woman in her late 40s. She comes in about a week after her permanent stim, and this is what I see. And she's complaining of excruciating back pain. Excruciating. 46-year-old female. She's morbidly obese. She's a type 2 diabetic. She's a risk classification of 2. Permanent implant a week ago. Severe soreness. Can't sleep, can't lay on her side, but her labs are all normal. We just put her under surveillance, kept her antibiotics going for another week, and she did perfectly fine. Case number 2, infection or no infection. How many people think this is an infection here at this battery site? Infection or no infection? So infection, we have 3 people. Actually, this was a kid who was severely immunocompromised, 25-year-old law student who had a stimulator put in January, who came in to see me in April. He slept, it was a rechargeable system, that's what he wanted. He slept on his charger overnight for 2 nights in a row, and he had this large sinus between the pulse generator and the external environment. Take a look right there. And I was extraordinarily concerned. I called Tim Deere and said, Tim, what do? I said on the picture. Tim said, take it out. I said, really? He goes, anytime you can see the can or the battery, it must come out. So I said, I don't know, we're going to do some labs here. Sed rate was okay, C-reactive protein was okay. He was afebrile, no drainage. And so I didn't listen to the great Tim Deere. Okay, I had this staring me in the face. I put a little bit of Dermabond on it. I waited. I put an occlusive dressing with some steri strips and a Tegaderm. And I waited, and sure enough, 6 weeks later, he did perfectly fine. So every once in a while, even the great Tim Deere can be fallible. But that doesn't mean if you see that, you leave it in. If you see the can sticking through the skin, the rule is, when in doubt, take it out. Okay? The solution to pollution is dilution, and I think this is important. I flush my wounds really with a huge amount of antibiotic-based solution whenever I do any permanent implants. So, death. I'm going to finish up right now instead. I apologize. I'll be done in 90 seconds. Death is a rare event with interventional pain management. Anyone ever have a death in your office or in your practice? Seriously, raise your hand. Did you ever kill a patient during interventional pain management? Anybody? So there's 3 cases where I served as an expert witness on. I'm going to show you they weren't all happy outcomes. Usually preventable, disproportionately expensive, and I got these from the Illinois Jury Verdict Reporter, which is a newspaper that is out there for public consumption, which publishes the results of every medical malpractice case that happens in the state. So here's a really regrettable case that occurred in my state where I was the defense expert, and we lost. You can see it's an $8 million verdict for a celiac plexus block that led to death. Now I have to tell you why I published this and show you this. I was defending the anesthesiologist who did celiac plexus block that led to death. And really, what was atrocious was that the plaintiff's attorney came to the defense attorney and said, listen, I just want to get rid of this case, give me $250,000. And the defense attorney came to me and said, what do you think? I said, absolutely. He said, it's a death, it's a horrible outcome from celiac plexus block, just pay it. But the doctor, who was the defendant, said, no, we got Candido, we're going to win this case. Well, guess what? We lost the case for $8 million. And it wasn't because of lack of trying. They found out, it was done at a surgery center, they found out that the guy who did the celiac plexus block didn't have clinical privileges for celiac plexus block. He had for spinal cord stimulators, and he had for intrathecal pumps, and he had for vertebroplasty, but they never checked off the box for celiac plexus block. When the jury saw that, bingo, $8 million, so we lost that case. Here's another case I served as an expert witness on, $3 million, cervical epidural steroid injection. 52-year-old woman with 4 kids died having a cervical epidural steroid injection. Now, I defended the proceduralist, and we were successful. The case was lost because the anesthesiologist gave Versed, fentanyl, and propofol during the procedure in fairly robust doses. The proceduralist did the procedure, it was uneventful. The patient goes to the recovery room. The anesthesiologist doing the sedation, and the nurse left the patient unattended to start other cases, and she had a respiratory event and died. And so, can you imagine, the husband and the 4 kids are in the waiting area when this 52-year-old mother of 4 is having a procedure. Suddenly the ambulance comes in, right? And the stretcher comes in, and the husband's sitting there reading Time or Newsweek, and suddenly his wife is coming out with an endotracheal tube, and she died. And so we lost that case. I didn't lose the case. We lost the case on the merits of the anesthesiologist who didn't surveil the patient. Here's a case which I thought went okay. It was against the most prolific medical malpractice lawyer in the state of Illinois and probably in the whole country. They were suing for $10 million, and we were able to settle that case. At least me as an expert was able to convince them to pay $350 and walk away. And so that's always the decision you make when you have a bad outcome. Do you pay or do you fight? Do you give up some money and go to the National Practitioner Data Bank, or do you sit tough? And so my final conclusions: proper planning prevents poor performance sometimes. I think that when you're choosing transfemoral injections, you really need to determine whether your patient needs a transfemoral injection. Remember, the evidence does not favor transfemoral injections. Don't use DSA, it's not going to protect you. There's no evidence at all to support it. Avoid insoluble steroids, at least in the cervical spine, drugs like methylprednisolone and triamcinolone. Avoid deep sedation, because only bad things happen when you sedate your patients too deeply. Go slow, tread easily. And proper patient selection is important. And for other infections, make sure that you use antibiotic, weight-based, hair depolation right before the procedure. Brief operating room times. If your times are exceeding the 75th percentile, you need to reevaluate your technique and maybe take another course. Culture suspicious wounds. Get sed rates, C-reactive protein, follow the trend, but if there's any concern, take out the device at the earliest possible convenience. I'm sorry I went over 5 minutes, Stan. There's a lot of material to go over. I think it's important that we tell our patients that procedures that we do can cause worsening of their pain. That should be in your informed consent for every patient that you touch, whether you're just doing a trigger point injection or the most invasive of invasive things. Tell your patients that what we do can cause harm. Don't minimize the risk to your patient. Thank you very much.